Hello, this is Mohammed Al-Azmi, and today I'm going to talk about a disease known as hyper-IgM syndrome. This slide shows an overview of a hyper-IgM syndrome, which is a rare immune disorder that significantly affects the body's ability to fight infection. Patients with hyper-IgM syndrome have abnormal immunoglobulin levels. Specifically, they exhibit normal or elevated of IgM alongside with reducing the amount of IgG and IgA as well as IgE. As we know that IgG is the most abundant antibodies in the bloodstream, IgA it is very important for mucosal immunity, and IgE is important for parasites infection. Now let's look at the different type of hyper-IgM syndrome, focusing on the genetic mutation and that define each subtypes. The first group is called X-linked hyper-IgM syndrome, caused by mutation on the CD40 ligand gene. It leads to impaired the interactions between T cells and B cells, and this presentation is going to focus on this type of deficiency. The second group is called autosomal recessive hyper-IgM syndrome, can be caused by mutation in various genes involved in class switching, such as AID and UNG. Now I'm going to talk about epidemiology of this disease. X-linked hyper-IgM syndrome occurs in about 1 in 1 million births. CD40 ligand deficiency affects around 2 in 1 million males. ICDL deficiency is even rare, affecting fewer than 1 in 1 million people. HIGM makes up 0.3% to 2.9% of all primary immune deficiency globally. On this presentation, I'm going to focus on CD40 ligand deficiency. And CD40 ligand deficiency is a genetic condition that severely weakens the immune system, most commonly showing in the boys by the age of 2. This condition results in low level of IgG, IgE, and IgA, while the IgM remains normal or high. The deficiency occurs because the body T cells do not function properly and they fail to express adequate levels of CD40 ligands, which is a protein necessary for B cells to produce different types of antibodies, and this limits the immune system ability to fight infection effectively. Here we will look at the genetic causes of CD40 ligand deficiency and how it affects immune function. Okay, the location of CD40 ligand gene on the XQ26 encodes the CD40 ligand protein. In X-linked hyper-IgM syndrome, gene mutation results in low or abnormal CD40 ligand levels. CD40 ligand and CD40 binding in B cells trigger immunoglobulin class switching as well as hypermutation, somatic hypermutation. Without CD40 ligand and CD40 interaction, B cells cannot go under class switching or somatic hypermutation, which results in the production of only IgM and reduce the level of IgG, IgA, and IgE. Before diving to this disorder, it is very important to understand the two main types of immune responses. First type is called innate immunity. This is the first body line of defense. It responds very quickly using physical barriers such as skin and immune cells such as neutrophils and macrophages to fight infections. On the other hand, adaptive immune system, this is more specialized. It takes longer to activate but uses B cells and T cells to create targeted responses. And this system also has memory, meaning it can recognize and respond more effectively to the same infection in the future. Now let's discuss the primary antibody repertoire, which is the initial sets of antibody B cells produce. It is generated in the bone marrow through the process called VDJ recombinations, where the different gene segment rearrangement to create a diversity antibodies. This process is antigen independent, which means that it happens without the presence of any specific pathogens. The results is low affinity IgM and IgD antibodies, which are the first lines of defense before the immune system refines its response. Next, we will take a look at the process that occurs in the peripheral lymphoid organs, which is crucial for the adaptive immune response. This process is antigen dependent that requires T cells involvement. It involves a key interactions between CD4 ligands on T cell, as shown here in these figures, and CD40 on the B cells. This interaction is fatal for B cell activation and the production of high affinity antibodies, enabling more effective immune response. So when the B cells present antigen via MHC class 2 molecules, they receive help from CD40 T helper cells. T helper cells are activated by recognizing antigen and release cytokinases that help for the immune responses. Now I'm going to talk about antibody class switching in details. Class switching is a process that allows B cells to produce different classes of antibodies. Initially, activated B cells produce only IgM, which is effective in the early stage of immune response. Through the interactions between T helper cells and B cell can undergo class switching to produce IgA, IgE, and IgG. The mechanism of a class switching cytokine involves cytokines such as IL-4, IL-5, interferon gamma, and TGF-beta, which play a critical role in signaling B cells to switch from IgM to other antibody classes. IL-4 is very important for switching to IgE or IgG1, which is important for parasitic infection. Interferon gamma drives switching to IgG2A and important for opsonizations and activating complement. And TGF-beta induced switching to IgA, crucial for mucosal immunity. The class, this is very important mechanism. The second important mechanism, which is somatic hypermutation. Somatic hypermutation is a random process that introduces mutation into variable regions of immunoglobulins genes in mature B cells. This mutation can change the binding specificity and affinity of antibodies, which expands the antibody repertoires and selecting for high affinity of antibody. Let's move on to talk about the case involving a young patient. Dennis was brought to a hospital with a chief complaint with a severe acute infection of ethmoidal sinuses, and this is also known as ethmoiditis. The history, notably the patient has a history of recurrent sinus infection since he was 1 year, indicating a potential underlying issue with their immune response or sinus anatomy. Now let's take a look at the patient medical history and the laboratory finding to better understand the context of his disease. The child has a history of recurrent sinus infection when he was 1 year. At the age 3, the patient experienced pneumonia caused by pneumonocyte gyrophysi, and which was successfully treated with antibodies. Now at the age 5, the patient is presenting with epididymitis, and the cultures from the nose and the throat reveal a group of A beta hemolytic streptococci, and notably the laboratory results show the low white blood cells counts, and which is below the normal range. This includes also the low levels of neutrophils and normal lymphocytes level and elevated of monocytes. It is very important as a doctor to take a look at laboratory finding and focusing on the white blood cells counts and immunoglobulin levels, which provide important insights into their immune function. As I mentioned before, white blood cells are low, including neutrophils, and when it comes to the lymphocytes are within normal range and monocytes are elevated. In addition to the white blood cells count, immunoglobulin level reveals significant finding, including IgG, which is low, and IgA is undetectable, indicating a potential issue with mucosal immunity. Now we will discuss the lymph node biopsy, which refers to the poorly organized lymphoid tissue with absence of germinal center. The second one is going to be antibody response. Antibody response is concerning the patient shows no antibodies to the streptomycin or the tetanus after receiving the booster vaccine. This suggests that an adequate response to vaccinations, and also, however, there are elevated IgM antibodies against the blood group antigens. And lymphocytes analysis, in the lymphocyte analysis, CD19 plus TCD3 cell counts are normal, but notably the B cell only expressed IgM, IgD, which means that there is no class switching or somatic hypermutation. Importantly, T cells fail to bind CD4, which suggests a deficiency in CD ligand, crucial for effective B cell activation and class switching. So this is emphasized that CD40 ligand deficiency, which leads to impaired to class switching and recurrent infection. Now let's discuss the diagnostic measures taken to confirm the patient's conditions. Immunoglobulin levels. First, we measure the levels of immunoglobulins indicating IgM, IgG, and IgA. A diagnostic is supported by high or normal IgM alongside low or absent levels of other immunoglobulins, which aligns with the patient finding. The second one, it's going to be flow cytometry. Flow cytometry is employed to detect the absence of CD40 ligand on activated T cells, which is a critical indicator of immunological function. The third one, it's going to be DNA sequencing. Finally, DNA sequencing confirms the diagnosis by identifying the mutations on the CD40 ligands gene located in the X chromosome. This genetic analysis provides definitive evidence of underlying conditions. Together, this diagnostic approach helps clarify the patient immune deficiency and guide the appropriate management. To start with, Dennis was treated with intravenous antibiotics to address his severe acute erythematitis. Next, Dennis received a series of poster fixations that are designed to stimulate the immune system and produce antibodies against these pathogens. However, the follow-up testing showed no detectable antibodies against tetanus or typhoid after 14 days. After that, he was treated with intravenous gamma globulin. This is very important for providing passive immunity. And for the diarrhea at the age 15, Dennis developed severe diarrhea caused by Cryptosporidium, and he was treated with antibiotics, which is often effective against various infections. Now let's explore the clinical feature commonly associated with CD40 ligand deficiency. This condition typically begins in infancy with recurrent respiratory infection, also develop opportunistic infection such as pneumonocyte Jirovecii pneumonia, and furthermore chronic or recurrent diarrhea leading to failure to thrive, and neutropenia common, and thrombocytopenia and anemia less common. Autoimmune inflammatory disorders such as Crohn's cholangitis, and the last thing, increased risk for certain cancers. Let's talk about the management of this disorder. The first drug is going to be immunoglobulin replacement therapy, which restores the immunoglobulin levels to the normal. The second one is going to be combined with the first one, prophylaxis therapy for the opportunistic infection. The third one, management of neutropenia by granulocytes clone stimulating factor. The most effective therapeutic option for hyper IgM syndrome type 1 is hematopoietic cell transplantation. Study by January reported 58% overall cure rate with hematopoietic cell transplantation regardless of organ damage. It's important for monitoring of CD40 ligand or CD40 ligand deficiency, which include liver function, requires regular assessment every 4 to 6 months. And the second one, it's going to be ultrasound evaluation conducted annually, and stool PCR for cryptosporidiums or microsporidiums, preform like twice a year. If positive, initiate the prophylaxis therapy. Unfortunately, poor prognosis despite therapy. Common causes of death including opportunistic infection and malignancy. Survival rates is like 60% at 20 years without liver disease and 20% with liver disease. These are my references, and thank you for watching and have a good day.